So menin inhibition in acute leukemias and specifically in AML have really demonstrated a significant step forward in the relapse refractory setting. So at this time, when we're thinking about KMT2A rearranged acute leukemia, whether that be ALL or AML, we have revumenib as the FDA-approved option. And then for NPM1 mutated relapse refractory AML, we have both revumenib and ziftomenib. Ultimately, in the single agent setting, in the relapse refractory setting, response rates, and particularly complete response rates, hover right at about 20 to 23%. So an effective drug, but the majority of patients do not respond to menin inhibition as a single agent in the relapse refractory setting. With this in mind, there's been much interest to move up menin inhibitors to the frontline setting. So that's looking at both the combination of intensive chemotherapy plus menin inhibitor for patients with NPM1 or KMT2A rearranged AML. And also in our lower intensity approaches, looking at the triplet of azacitidine, venetoclax, and menin inhibitor. So currently, we have data that's either been generated or in the process of being generated for several menin inhibitors in this space. And so far, I would say the commonality is that certainly the depth of response, when I'm talking about depth of response, I mean not just achieving a complete remission, but also eradicating MRD, whether it be by an NPM1 PCR assay or a more sensitive assay for KMT2A rearrangement. There certainly seems to be a deepening of response when you add the menin inhibitor to your frontline chemotherapy regimen, whether that be intensive chemotherapy or whether that be a lower intensity regimen like aza-ven. I think the bigger question, and there are a wave of phase 3 studies that will help to more definitively answer this question, is does that deepening of response translate to a survival benefit? So when you look at your standard regimen with or without menin inhibitor, ultimately, does that deepening of response upfront translate into overall survival benefit for patients that are receiving the triplet? Or when you're thinking about overall survival, does sequencing therapy still make sense? Give someone their standard lower intensity or intensive regimen and hold the menin inhibitor in reserve if and when there is relapse or progression of disease, while recognizing that the complete remission rate of a single agent menin inhibitor in the relapse refractory setting is approximately 20 to 25%, and that's really been the case no matter what menin inhibitor we use.